Good afternoon, everybody, and welcome to Care Connection, the free live webinar. Today we have our special edition Care Connection, and the topic is Making Advanced Care Planning Easier. Our special guest is Dr. Rebecca Sidore. She's a geriatrician, palliative medicine physician, and clinician investigator. A clinical investigator. She also directs the Innovative and Implementation Center in Aging and Palliative Care and the Vulnerable Populations for Aging Research core of the National Institute on Aging funded Pepper Center. Dr. Sidore conducts research to improve advanced care planning and medical decision-making for diverse, vulnerable older adults. We are so happy to have you today as our guest presenter. Before we begin, I just want to let everyone know that this is in listen-only mode, that on the right-hand side, you will see a control panel. At the end of the presentation, you could type in your questions or comments. In addition, the handout for today, the PowerPoint is in PDF under handouts. So Dr. Sidore, thank you for volunteering your time, and we're going to begin today's presentation.
Great. Thank you so much. Can you hear me okay?
Perfect. Thank you.
Okay. All right. So yes, we're going to be talking about making advanced care planning easier for vulnerable populations, including those with cognitive impairment. And, when I give these talks, I like to start out by just getting us all on the same page about what advanced care planning is. This cartoon says we're on the same page, yet we can't seem to agree on anything. And I bring that up because our team actually published a consensus definition of advanced care planning where we got 50 experts in advanced care planning from around the world actually to come and talk about a definition of advanced care planning. And I can tell you they had a hard time coming up with a consensus definition. So I will read to you what we determined in this large group, that advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And that the goal of advanced care planning is to help ensure that people receive medical care that's consistent with their values, goals, and preferences during serious and chronic illness. And I think the things that you will find absent from this definition are things that are only focused on end of life and a one-time event or only focusing on advanced directive forms. So when, I think about advanced care planning as a process, this is sort of a schematic from Respecting Choices model that talks about first steps, next steps, and what they call advanced steps. And people often think about this in terms of life course, but I also think about this in terms of readiness to engage. We all know those patients who might have end-stage cancer, but really are not ready or, feel confident to sort of engage in advanced care planning. And just to say that my work has really focused on this first steps area, trying to move advanced care planning upstream, whether you're upstream in, your life course or in somebody's readiness to engage. I think as well, when we focus on prevention, and I'll talk about this a little bit later when we think about advanced care planning, when we think about cognitive impairment, I really try to sort of engage people who have either no cognitive impairment or mild cognitive impairment. And I think we know that some of the issues related to informed consent when we get to moderate or advanced dementia, can be problematic. But I will come back to this a little bit later. So advanced care planning, we know for many clinicians, this can be very hard as well as for patients. And again, can we make it easier? I would say for clinicians, things that I have heard are that people, and I'm a primary care geriatrician as well as someone who does inpatient palliative care consults, and I would say it's hard in both of those settings. I think what I've experienced and what I've heard is that people don't have time. It's a hard topic to bring up. They don't know what to say, and often patients aren't prepared. So I think the objective today is, I want to spend just a few minutes talking about health literacy and cognitive burden when we talk about advanced care planning, a little bit about language and culture, and then again, how can we make this easier for us and for patients? So for clinicians, considering sort of an alternative approach to advanced care planning with an easy 3-step process. For patients, using easy-to-use patient-facing tools, and then I thought you might be interested in some of the work that our team is doing to get advanced care planning out to the community. So advanced directives and cognitive burden and health literacy. So this cartoon says, you don't call this a legal document, do you? I can read, I can understand every word of it. And I think this has been sort of a problem with advanced directives, just like our consent forms. They're really written with very difficult legal language. It's hard for patients to understand. So here's an example of a form that was being used at our county hospital. It was written at 8-point font. You can see there isn't very much white space and had a lot of legal language. And I was on the ethics committee, and we sort of learned that over 15% of our ICU patients were being unrepresented, and patients at our county hospital have very low rates of advanced care planning. And you can see this form creates very high cognitive burden. And so, for people who don't know, just a little bit about health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate decisions. And I say process because other things may be going on with someone, such as emotion from a diagnosis they may have just received. Many people don't know that the average reading level in the U.S. is only at the 8th grade. And for Medicaid recipients and the elderly, it's only at the 5th grade. But again, we often give people information written at a 12th grade reading level. And as I said, when you overlay emotion on top of all of these things and a topic that might be hard to engage in, it makes the processing information much harder. I think there's also language considerations we should think about. So 61 million people in the U.S., or about 20%, speak a language other than English at home, including 40 million Spanish speakers. And there have been sort of a lack of linguistically appropriate materials. And there's cultural considerations. So many people in the U.S. have non-Western views on autonomy and decision-making. For example, in our study populations, we find out that about 20% don't want to make their own medical decisions, and they want somebody else to do that for them. There also is a great deal of mistrust, and I would say this is perceived racism, I would say experiential racism, and minorities are given less information by clinicians and less time for discussion, and many people mistrust forms. And so we have to think about these things when we're thinking about advanced care planning. So we spent many years, and our team worked closely with the community to sort of co-create an easy-to-read advanced directive. It's written at a 5th grade reading level and has pictures that help describe the text. We had conducted a randomized control trial many years ago now, where we showed that we were able to double the completion rates of advanced directives, and people overwhelmingly preferred this easy-to-read version over a standard version. And this is really regardless of whether somebody had high literacy or low literacy, or regardless of their language. The advanced directive is available in 10 different languages in California, and in the U.S. it's available for all 50 states in English and Spanish on our prepareforyourcare.org website. So now thinking about for clinicians and thinking about the way that we think about advanced care planning, and is there something that we could do to make it easier for us when we talk to our patients? So the traditional objective of advanced care planning has been to have patients make treatment decisions in advance of serious illness in an attempt to provide care that's consistent with their goals. And that's a great goal. We've often used advanced directives and PULSE to help us do that. But I think clinicians, like lawyers, we sort of like our check boxes, and we want to know, are you DNR, DNI, do not resuscitate, do not intubate, yes or no? We check off the box, and then we think that we're done with advanced care planning. And as you know, we just created an easy-to-read advanced directive, and we think that they're great, but maybe they're not the big, all of the picture. We do know that advanced directives are helpful. So if somebody has an advanced directive, Studies have shown that there's better communication between the surrogate and the doctor, but surrogates still report very high stress. There was a study that was done in New England Journal of Medicine back in 2010 that showed that if people have advanced directives, they're more likely to get the care that they want, or would have wanted in their very last days. But what we don't know is that this was all by proxy report up to 2 years later. So there's a lot of recall bias there. And we also know that many of our patients, including those who have dementia or cognitive impairment, live for many years, and there are many decisions that need to be made over time. And what we don't know is whether advanced directives shape the decisions in the last months or the last years. We also know, if we only focus on advanced directives only, that there's some problems with this. We know that this information is often not available when needed, even though electronic health records and pulse forms are trying to help with that, and that is improving. We also know that if somebody has an advanced directive or a pulse, it doesn't often improve somebody's knowledge of patients' preferences in a particular clinical situation for either a surrogate or physician. It doesn't always affect care or cost at the end of life. And again, it doesn't always prevent surrogate stress or conflict if we're only focusing just on the form. So again, this sort of begs the question for our team, or whether advanced directives are enough. And I'm going to read you a quote from one of our many focus groups from patients and surrogates. And this was from a surrogate who said, "We got the DNR in writing, but in making the decisions, which there were many, that was just one. Because the first decision was to put him in a nursing home. We were married 30 years and I could no longer take care of him. Then the second decision was whether to put him on a feeding tube because he had stopped eating and I wasn't ready to let him go." So I think we know that sort of no form or checkbox will ever eliminate the uncertainty and the complexity of the human condition. So I would say that our field continues to keep trying to do that by having people complete checkboxes and then we think that we're done. But people really need better preparation over time. So what do we discuss? What do we discuss for terminal patients who might not be ready to have a conversation with us? What about for non-terminal patients who have a chronic illness? Do we focus on life-sustaining treatment such as CPR or mechanical ventilation or something more than that? And really the question is, how do we prepare people for these discussions and decisions that they might be making in the future? So one thing, just to back up for a moment, the problem with only focusing on treatment decisions such as CPR and mechanical ventilation is that these treatment decisions can be flawed based on prediction, adaptation, and extrapolation. And I'll tell you what I mean. When we talk about problems with prediction, many sociologic and anthropologic studies show that people cannot predict what they're going to have for dinner or buy at the store 20 minutes ahead of time, much less the exact medical care they will want in every clinical context in the future. And the problem is that predictions don't reflect someone's current medical, emotional, or social context. And we also know from a large amount of research that preferences change, but they change not only during changing health, they change during stable health, and they change at the end of life because we're human and that's just what we do. There's also uncertainty about a lot of these hypothetical scenarios that we say to patients, such as if you were in a coma, if this were to happen to you. And we asked sort of this question of we found that 50% of diverse older adults who had reported a treatment preference based on a hypothetical scenario that they were given were uncertain about their decision. And uncertainty was associated with limited health literacy and lower education, and interestingly, poor health status. So we have people who complete their advanced directives, and we think that they're certain about their choices, but in many cases, they are not. This is a quote from our focus groups. I don't think people know how they're going to feel until they're faced with a situation. They may have all kinds of theoretical ideas or something they read in Dear Abby, but when the time comes, you may be very surprised at your own reaction to something. I mean, it's not as easy as black and white. There are so many gray areas. There's also problems with adaptation. So people often say that they cannot envision being able to cope with disability, but many studies show that once people are in those situations that they can. So again, saying to report a desire to forego treatment in such states, but again, once in those states, they're willing to accept even invasive treatment. And again, as humans, we're very adaptable beings. There's also problems with extrapolation, so decisions about less intensive treatment. So if you've made a decision about CPR or mechanical ventilation, how does this help with surgery or chemotherapy or nursing home? Or how does this help with a decision that maybe you've never heard of before? So for example, there was a patient who had reported on advanced directive that she wanted to be DNR/DNI, but she had received cancer treatment that had actually caused heart failure. And so she had come into the emergency room for her heart failure, not for her cancer. And the doctors felt that if she went to the ICU, that they could get her over this hump and get her back home. And that's exactly what happened. And so she and her family, she could make her own decisions, but they reversed that code status. But just to say that we can't always look into the future to know and extrapolate prior decisions. So now what? Well, some people will say, well, why don't you just designate a surrogate decision maker and sort of, that should just work out fine and we can sort of be done with it. But again, many studies show that surrogates don't know that they were chosen. The knowledge of preferences for, patients have been shown to be no better than chance. Studies are also showing that these surrogates live on with stress, anxiety, and PTSD from having to make these decisions for people. And people also use their own hopes, desires, and needs in the process. So this is a picture actually of my grandparents. And I tell this story and actually published it in JAMA because it was so impactful to me in my career. But my grandfather was very sick. He had fallen and broken his hip. He had been in and out of hospitals. He had, after they did his surgery, they kept him sort of in bed, and he wound up having decubitus ulcers to bone. He never walked again, and he was back and forth for surgical debridement and nursing homes. It was just a really hard and horrible path, and no one had talked to him about his wishes. And I sat down, this is way back when I was a geriatrics fellow, and asked him sort of what was important to him and what he wanted. And we sat there with my grandmother, and again, he said, I'm tired, I'm not afraid of dying, no breathing tubes, no shocks, no pushing on my chest, just let me go. And we had a long, very clear conversation, and I turned to my grandmother and I asked her if she understood and what she would tell the doctors. And she said, of course, I would tell the doctors to do everything possible to keep my husband alive. And so you can see that just because you chose a surrogate doesn't mean that you're necessarily going to get the care that you wanted, but I will come back to this story in a little bit. So why, some people will just throw up their hands and say, why do anything in advance? And there's a camp of people who think, maybe we shouldn't be doing advanced care planning. But I can tell you that, clinicians, we can't make recommendations or guide patients or their family members in decision-making without the patient's values and needs. And sadly for the patient, this is highly individual, and it can only be provided by the patient or the surrogate. And you can imagine that without preparation, patients and surrogates will not be able to communicate their values effectively, especially if they're sick, especially if there's high emotion and stress, and especially for people who might be coming into the hospital and have no prior relationship with the doctors that they may be, doctors and nursing staff and other clinicians that they might be seeing when they are in those situations. So we started thinking about a paradigm shift. So this cartoon says, I'm afraid you've had a paradigm shift. And we published a paper in 2010 called Redefining the Planning in Advanced Care Planning, or Preparing for End-of-Life Decision-Making. And this shifts the focus from only talking about life-sustaining treatment and really focuses more on preparation for communication and decision-making. And so I think what it really seeks to do is to prepare people with skills to identify what is most important to them, which is evolving over time, to communicate with surrogates and providers, and then to make informed medical decisions over time. And if, within this sort of framework, advanced directives are highly important, but they should really be a marker of full preparation and reflect these discussions over time. So how best to prepare? So when we think about what matters most to people, it's the outcome. So it's the outcome of treatment. And if you can see on your screen here, I have a little picture of a cart before a horse. And so it's not really intubation or CPR, which is the cart, but it's how their life will be after treatment or the horse. And I think we in the medical field often focus on the cart or CPR when we really should be focusing on how somebody's life will be after treatment. So this quote says, "Are we reviving him, sticking the tube in so that he can suffer more?" I guess it goes back to what happens if you revive him. Is he going through that whole process again? It's the end result. So we've talked about outcomes, but what about stories? Stories can frame values about outcomes, prior stories about somebody, themselves, or about family members or friends. And we had actually done a study way back during the Terri Schiavo media frenzy. For people who don't remember, she was a woman in a persistent vegetative state, and there was a Supreme Court order to remove her feeding tube, and this was all over the news. And we found actually that this news story had reached 92% of diverse English and Spanish-speaking older adults at our county hospital. And I think more importantly is that due to that case and media coverage, 61% of those people had clarified their own goals for medical care. 66% had spoken to others about their goals, but only 8% had spoken to their doctor, which is really a missed opportunity. But all to say that we could use this idea of stories as very powerful ways to help people identify their values. And then I think helping people reflect on changes in their stories. So on whether people are changing or adapting to serious illness. And studies show that when you do this, it really helps people better predict their preferences. So as their disease trajectory progresses, to become more specific. So when you were in the hospital with heart failure, or the last time you were in the ICU when you were intubated, tell me about that, and how you feel about that, and would you be willing to do that again? And then I think this is really highly important in terms of surrogates' need for preparation. So up to 3/4 of patients, all of us really, will be unable to participate in some or all of our own decisions at the end of life. Yet surrogates report being unprepared to make medical decisions. They were never asked to play this role. They don't know what their role is. And again, as we talked about, it's been highly stressful, and patients or surrogates have been having PTSD. So another quote from a surrogate: "The only thing I managed to talk to my father about was if anything should happen and his heart should stop. That was the extent of how much I knew what his wishes were. The other stuff we were guessing at as to know whether he would want to be home or in a hospice." So another piece when we think about surrogates is something called leeway. So surrogates may need to make decisions that conflict with patients' preferences. So I see this a lot in my geriatrics practice, where someone, frail elderly spouse can't honor their spouse's wish to die at home because they physically can't take care of them. Or somebody's asked to withdraw care, or somebody may benefit from transient treatment, and the surrogate has to make a decision that may be different because the context has changed. And studies have shown that surrogate burden can be eased by giving them permission to consider factors other than prior wishes during in-the-moment decision-making, and this is something called leeway. Studies of leeway have shown, when we asked how much leeway should your physician or surrogate have to override this advance directive, well, 39% said no leeway, but 19% said a little, 11% a lot, or 31% said complete leeway. And it's one of those things that if you don't talk about it, it's one of the things that becomes an ethical problem, and what I hear on our ethics committee after the fact. But if you talk about it ahead of time, from an ethical standpoint, it's still an extension of a patient's autonomy. And if it's documented, this can really sort of help the process. So we'll come back to that as well. But in terms of surrogate leeway, this is very well illustrated with my grandparents. So who, as you recall, my grandfather said, "I'm ready to go, please let me have a natural death." And my grandmother said, "I would tell the doctors to do everything possible." And I turned to my grandfather and I said, "Well, this could be a problem. And how do you feel about the fact that grandmother feels this way?" And he said, "I'm ready to go, but if it helps your grandmother to feel that she did everything possible for me, even if it's because she doesn't want me to go, that is okay. she's the one that has to go on living with her decision. If this is what she wants, then this is what I want because I love her. And at the time, I didn't really understand this. I was upset. I was wondering if we needed a different surrogate. But my grandfather wound up, dying in his nursing home. They called a code and he never recovered. And my grandmother felt like she gave him a fighting chance and she felt good about her decision. And it's really opened the door for me to be able to continue to talk to her about her own end-of-life wishes. So let's talk about 3 steps for clinicians and what you all can do. I would say that all of this information is in that publication of Redefining the Planning in Advanced Care Planning that can be found in the Annals of Internal Medicine from 2010, and it should be here in your slides as well. But I think if we focus on helping people choose a surrogate and ask a surrogate, clarify values about the outcome of treatment, so how their life will be, not just about CPR, and reassess over time for changes in wishes, and then establishing leeway in surrogate decision-making or permission to change prior decisions. So I think these are all of the things that we as clinicians can do and the ways to sort of make this easier. Again, this paper in Annals really walks you through a step-by-step process with words you can say. So for the surrogate, is there anyone you trust to make decisions for you? Does this person know that you chose him or her for this role? And what have you talked about? Sometimes when I'm seeing patients either in the emergency room or in the hospital or I'm in my clinic and I ask this question, this is the only question that I have to ask because maybe they don't have an advance directive, but they've already been talking to their family members about what's important to them, and this can start the whole conversation. This is a way that it might make things easier on us. Step 2, really focusing on stories. So how do you define good quality of life? What does that mean to you? Really focusing on the outcome. And then, have you seen someone on TV or had someone close to you who had serious illness or maybe have died? What went well or did not go well and why? And if you were in this situation, maybe it's their own situation, so in this situation again, what would you hope for? And then clarifying values and goals. I often use something, I call it the spectrum question, and I actually use my hands when I'm talking to people to show that it is normal for people to be along a full spectrum of values and preferences. So I will say on one end of the spectrum, some people say that life would always be worth living, no matter what type of serious illness, disability, or pain they may be experiencing. And then I will use my hands and say all the way on the other side of the spectrum, other people feel that there may be some health situations or experiences that would make life not worth living, such as never being able to wake up from a coma or talk to family and friends. What type of person are you and why? And it's a rare person that can't sort of point somewhere on this spectrum, and it can at least start to spark a conversation. Step 3, if you're interested in sort of discussing leeway, so is it okay to use your medical wishes as a general guide to change your decisions if your doctors think it's best at that time? Or are there some decisions you would never want changed, even if the doctors are recommending it? And again, all of this is in that paper. And then I think, what our job is really then, it's our job to translate their story. So based on what you told me about what brings your life meaning, about how you felt about your loved one's experience, how you felt about your last hospitalization, it sounds as though X treatment or X life-sustaining treatment may be something that would or you would not want for yourself. And then, is this correct? And I think if we help people do the translation, which I would say that we as clinicians often expect patients to be able to do that transition or translation piece, if we do it and we make sure that we get their permission and make sure that we got this correct, they'll tell us if it's not correct. And you can, again, have a further conversation about that. So I'm going to move on now to talking about easy-to-use patient-facing tools, and we should have time at the end for questions about any of these things. So I think when we think about patients, I think the major communication deficits that I see are that patients are not empowered and surrogates are not empowered. So we just talked about how it can be hard for clinicians to have these conversations. And as I said, we often set a very high bar for patients and surrogates that they're supposed to know what the patient's values are, and they're supposed to be able to translate that, having not gone to medical school in many cases, to make these decisions. And so the missing puzzle piece that we have found and heard, and again, this gets back to that quote up above about whether or not advanced directives are enough, is that people really need skills. They need to be prepared to identify what is most important and how they want to live, to be prepared with skills to talk to family members and friends. How do you talk to medical providers? How do you make informed decisions? And then to prepare them to put that all together to advocate for themselves or for their loved ones to get the care that's right for them. So we tied all of that information and all the things that we learned about literacy and language and culture into prepareforyourcare.org, which is an online advanced care planning tool in English and Spanish. I will not bore you with the details, but we created Prepare based on many different theoretical constructs, mostly focused on behavior change. We had an expert panel of experts in health literacy, geriatrics, palliative care, and behavior change. We conducted 13 focus groups with patients and surrogate decision makers. You've heard some of those quotes today. And we conducted extensive cognitive or in-depth one-on-one interviews. And the cornerstone really of the website are videos that use video stories. We talked about how important stories were that model behavior. So we didn't want to just tell people to do something. We wanted to show people how to do something. So I think the other pieces of Prepare that sort of set it apart is that we really tried, just like the advanced directive, to make it easy to understand. It's written at a 5th grade reading level, again, ways to decrease cognitive burden. It has large fonts. It has voiceovers and closed captioning. With our limited budget, we tried very hard to balance the content of the videos on race, ethnicity, and gender, stories about people who wanted aggressive treatment versus comfort care. Surrogate availability, we have found that about 15% of our research participants will report being socially isolated and not having someone to act as a surrogate. And then we also needed tailored content for people who have different views on decision making. And again, we find that about 20% of people will report they don't want to make their own medical decisions, and we needed tailored content for that. So Prepare is sort of interactive. We call it multimedia because it has videos and things, and it's a 5-step process that walks people through advanced care planning. You'll notice that many of these steps look very similar to the clinician steps that we talked about before. So 1, choose a medical decision maker. 2, decide what matters most in life. 3, choose flexibility for your decision maker. But 4, then how do you tell others about your wishes? And how do you ask doctors the right questions? So this is just an example. We don't have time today to go through the videos, but this would be how to do it. So how to ask somebody to be your decision maker with actual words somebody could use if they wanted to use this to ask somebody to play that role. How to overcome barriers. So if people are not ready or they're having barriers, such as they think that advanced care planning is scary, there's stories, video stories that they can watch about that. How do you tell others about your medical wishes? And again, how to ask doctors the right questions to get the medical care that's right for you. As people are going through the website, they are answering values questions about what's important to them. And this gets compiled into what's called a summary of my wishes, which is again written at a 5th grade reading level, and they can use this to spark discussions and to help fill out advanced directive forms. And I'll talk about this in a little bit. The Prepare Now also creates an advanced directive for California, and that will be ready for other states in the coming months. So just to tell you a little bit about some of the data behind Prepare. So we found that Prepare improves patient engagement. This was one of our very first pilots where we actually went to low-income senior centers with older adults, and 92% of people had never used a computer before. And in this study, we found that 40% of people had engaged in some form of advanced care planning, but 1 week after reviewing Prepare, that increased up to 100%. And Prepare was rated on a 9 out of 10 for ease of use. We then did a series of randomized control trials, again, because we had heard that barriers to advanced care planning include lack of time, resources, limited health literacy, the issue of cognitive burden, and it was really unknown if we used these patient-facing advanced care planning interventions, can we overcome these barriers to advanced care planning in busy primary care settings? And what I mean by that is when you do advanced care planning, you can focus on the clinician or a facilitator, you could focus on the healthcare system and workflows and electronic health record, or you can focus on the patient. And these trials, what we did was we gave things to patients, and then we wanted to see what would happen if we did nothing else on the health system side. So in these trials, we randomized people either to our easy-to-read advanced directive or the easy-to-read advanced directive plus Prepare. And I can tell you that the Prepare group statistically significantly increased advanced care planning behavior change. These are things such as reported self-efficacy or confidence, readiness, having discussions, more than the advanced directive alone. And we found, this is in our VA study, that at 6 months before the study, their advanced care planning documentation rate was 1%. With the easy-to-read advanced directive, we actually got up to 25%, which we were very happy about. But this increased up to 35% with Prepare. And again, this means that patients would be activated to bring this into their medical appointments and get this into the electronic health record. At our trial that we did at San Francisco General Hospital, which was in close to 1,000 patients, we had almost half were Spanish speaking and 40% had limited health literacy, and many people had limited internet access and were computer naive. We found the same thing among this diverse patient population, even among English and Spanish speakers, that Prepare increased behavior change. Again, things like readiness and self-efficacy to engage in advanced care planning, as well as self-reported discussions. And over 98% of our participants in the Prepare arm engaged in some form of advanced care planning. And then again, when we look at medical record documentation, this increased to 43% in the Prepare arm and had similar increases among English and Spanish speakers. So in conclusion, these easy-to-use patient-facing tools with minimal clinician or system-level input can increase advanced care planning documentation 25 to 35%. And by combining Prepare plus an easy-to-read advanced directive, it resulted in higher advanced care planning documentation and engagement than the advanced directive alone. So let's talk a little bit in our remaining minutes about how we're trying to get advanced care planning out to the community. And this is maybe where you also come in if you're interested in any of these tools to help us get the word out. So there are free Prepare tools on our website. We've got Prepare movie events and toolkits. We're in the middle of a pragmatic trial, which I can tell you about, and stuff that we're doing in the public libraries. So the free Prepare tools. There are Prepare pamphlets, which are easy to use and can be downloaded off of the website. We have an easy-to-use advanced directive and a question guide. The easy-to-read advanced directives, as I was saying earlier, it's in 10 different languages in California, but it's actually available in all 50 states in English and Spanish right now through a generous grant from the Gordon and Betty Moore Foundation. And again, these are free on the website. We are in the process of creating what's called a guided advanced directive step. So this integrates and guides users to complete the advanced directive. It basically also has pop-up information for as people are going through, if they want to know more information, it will bring them back to the Prepare content that will help them complete that information. And this is available in California and will be available in other states in the coming months. Again, this is the pamphlet that we were talking about that can be downloaded. We have it available in English, Spanish, and Chinese. And then I wanted to tell you a little bit about Prepare as a movie for group movie events. So we had created toolkits for creating movie events for libraries, churches, senior centers, as well as group medical visits. We tried to set this up that if you're out in the community, really no training is required. and someone can go through and use our Prepare movies to put on an event. And all of the information is actually in the Prepare movies. It takes all the text of the website and actually has a narrator that goes over that, as well as plays the other video stories. And we've actually done some testing to show that the movie Toolkit, that 100% rated it as easy to understand, and that 93% were ready to answer questions about preferences, and 97% would recommend the session to others. And this is what was in senior center participants. We've also done studies about group medical visits. It was a small pilot study looking pre to post at 1 week, and surrogate designation increased up to 85%. Form completion in 1 week increased from 9 to 24%. And again, people found the materials reported they were easy to use in this group medical visit format. We've partnered with National Healthcare Decisions Day and our San Francisco Palliative Care Work Group here in San Francisco to work with libraries and community organizations. And with this last National Healthcare Decisions Day, we had over 20 events with lay facilitators, hundreds of people with high satisfaction ratings. So just to say that if you're interested in putting on events, either in a community organization or even as a group medical visit, these seem to be working quite well. So just a word to talk about sort of cognitive impairment or mild to moderate cognitive impairment. We have conducted a pilot looking at people who have mild to moderate cognitive impairment to see whether Prepare can work in that group. And I would say this is literally hot off the press. And some of the things that we're learning in this feasibility study is that these patients who have mild to moderate cognitive impairment and their caregivers, that they report that they can use the materials, that they're easy to understand, and that patients and caregivers increase their readiness and engagement in advanced care planning. So again, we tried very hard to decrease the cognitive burden, and it seems like we maybe have struck a good balance there. So more to come on that. So a little bit about the healthcare system and thinking about the clinician and the facilitator. You know, we've gotten really great response just giving people, these easy to read tools, but we know that this would be much more synergistic if it was included in a holistic project that thought about the health system and workflows and the electronic health record, and possibly had a facilitator that was helping with this. So just to tell you that we're in the middle of a very large PCORI study at UCSF, UCLA, and UCI with about 10,000 patients who have serious illness. And what we'll be doing, we're sort of cluster randomizing these by clinic, where one group will get our easy-to-read advanced directive, the other group will get the advanced directive and Prepare, and the third group will get all of those things plus access to a navigator. And we're sending out sort of automated messages by mail and through the patient portal. And so, again, this is one of the ways we're trying to get this out into the community, and there'll be more results coming in the future about that. Next steps for us, for people who are interested, we're applying for funding, and if anybody knows of any funders who might be interested in these things, you can let us know. But we have some of our advanced directives in the pamphlet in Chinese, and we've started some preliminary things to change the text into Chinese, but we are looking for funding to update the entire website. And then we are looking to create modules specifically for surrogate decision makers and how do you prepare surrogates. I will tell you that since we have caregivers who have gone through Prepare with their loved ones, Prepare in and of itself really does prepare them. And so I would say the first step is always to do your own advanced care planning because I think that also helps prepare people for that role. I did want to tell people about some of my close collaborators and some things that might be helpful to you. I don't know if people know about a Goals of Care study that Laura Hansen from University of North Carolina published in JAMA Internal Medicine in 2016, but she created sort of a series of PowerPoint slides that people can go through that talk about patients' goals for care for individuals who have severe dementia. And so this is to help patient and family members who are trying to think about, wow, is a feeding tube right for me? is going back to the hospital right for me? And the primary goal of comfort was 65% enrollment, and it was 79% at 9 months, or death. So they felt that they, were able to increase, comfort care, and that was aligned with patients' wishes. They felt that they also had better quality of communication, improved concordance of goals, increased palliative care and treatment plans. It doubled the use of pulse forms, and it reduced hospital transfers. And I put this link in here for you because the PowerPoint slides and the presentation are available for free on this UNC website. So for people who are faced with having to make decisions for someone who already has, severe dementia, that can also be helpful. And I just wanted to let people also know about something here at UCSF that will hopefully be published here in the near future. These are some of my collaborators in the Memory and Aging Center, but they created something called the care ecosystem. And this is something that sort of includes not only the patient caregiver dyad, but also a lay health facilitator, as well as the healthcare providers, linking people to community resources, and having nurses and pharmacists and social workers together. I also gave you this link because you can get access to the toolkit on their website. And like I said, they said that the results from their study will be published soon. So with that, I will end, and we have plenty of time, it looks like, for questions, and I'm happy to answer any questions that people may have.
Thank you. This is a wonderful presentation. So now you are able to type in any of your questions or comments that you'd like to ask Dr. Sidore. One question is relating to palliative care. And what I'm seeing is that a lot of the individuals living with dementia are not offered palliative care. And I feel like that is something that would promote with the family advanced planning. What are you seeing with the promotion of palliative care with people living with dementia?
Yeah, I mean, I'm dealing with this actually right now in my own family. So it's a very topical issue. I think it all basically comes down to education. There are great resources. If people don't know that, the CAPC website, the Center to Advance Palliative Care, there are many great resources on that website that can help people talk about what palliative care is. They have educational handouts about what palliative care is that can be given to other folks, and they also have links to other resources. So again, I think if you're listening to this call, just like we're trying to sort of disseminate these tools in advanced care planning, I think it goes hand in hand with palliative care and sort of getting the word out. And I can tell you even though I'm a palliative medicine physician and I've discussed it with my family many, many times, they still ask, what is it again? What do you do? What is palliative care? And I think it really is a sort of public health educational initiative that needs to happen.
Thank you. And we do have a couple of questions in the queue. Does each state have their own prepare for your care?
Well, that's a good question because I think each state has their own laws on advance directives. And that's why we created 50 separate advance directives for every state to meet every state's laws. We work very closely with UC Hastings School of Law to make sure that everything is vetted legally. So yes, there are 50 different versions of our English and Spanish advance directives that meet every state's laws. The Prepare website itself we don't have a different version for every state, but the advance directive steps, when it actually gets to putting that stuff into a legal document, will be different for every single state in order to create those individual forms.
Thank you. What is the difference between a pulse form and MOLS form? Are they the same thing?
Yeah, so it's the same thing it's just that different states decided to call it different things. And different states have, they have the flexibility to put different things on their particular form. I don't remember what most stands for, but all of them are a physician type order. But they're essentially, they function similarly.
What would an out-of-state caregiver be able to access in order to educate their older parents?
Say that one more time. What would an out-of-state
caregiver be able to access in order to educate their older parents?
Mm-hmm. Like, what would they be able to access? Is that what you mean on prepare?
Yes, that's what I'm thinking. Mm-hmm.
Yeah. Well, that's a great question. I think it's one of the reasons as well that we're trying to get funding to create this separate module just for surrogates, because I would say that I am also a surrogate in a different state, and we hear this a lot from family members. It's very hard to be in another state when you're trying to start these conversations or to help with medical care. There's a couple things that someone can do depending upon your loved one. You could go to prepare, and like I always say, it's good to do your own advanced care planning. I have found that the best way to get my family members to do advanced care planning is if I've done advanced care planning and then I share my advanced directive with my family members, my mother, my grandmother, because it shows them that it's normalized, and we can't, necessarily ask people to do advanced care planning if we haven't done it ourselves. And I have found that really opens the door. It also sort of opens the door, especially if you're sharing your wishes and values and maybe an advanced directive form with them. It might show them or start to educate them about what their choices and options are. So that is one way to do it. The other way people have done it is to print out some of the free versions of things on the website and mail it to their loved one and ask to go over it with them together. You can sort of, through Skype. I have not done this myself, but I've heard people through Skype or other things like that have actually watched the videos together with their loved ones, which I also highly recommend, like sitting next to someone and watching and going through some of the prepare movies and website. That's also another thing that people can do to just sort of start those conversations. So I hope that helps.
Thank you. A written document can be interpreted differently by different people. Doesn't this make them dangerous, especially since they have legal force?
Yeah, so that's a great question. Was there more to that question?
No, that was okay. Just sounds like a question statement. That was all that was written. I'm sorry.
Yeah. I think a lot of people are worried sort of about that. I can tell you clinically that if somebody has an advanced directive and they have a surrogate, and this is one of the reasons to talk about leeway sort of ahead of time, is that if something was written on the form, but you've talked to your surrogate decision maker and they know in this, crazy new clinical situation that came up that actually something else is better for you at that time, and you've given them leeway, they can change your wishes and they don't have to go directly by your advanced directive if something is better for you at that time if you have a surrogate. And I think that's why just the forms themselves can be dangerous, because there's no context behind them. I think one of the things that we tried to do in our advanced directive is to allow people space to write down why they chose what they did, not just a checkbox, and why they feel the way that they did, whether it was an experience or why they want a particular person to make decisions for them, or why a particular treatment would be helpful, to try to get some context. But I think the forms without context, either written by the person or context from a surrogate decision maker because you've had, conversations. There, as a clinician at the bedside, can be very hard to interpret what does that mean in this current clinical situation.
Thank you. We have a couple more moments for just maybe one or two more questions. As we're waiting, I just want to thank you so much, Dr. Sidore, for this informative presentation. I certainly learned new information today. And we've been getting flooded with many thank yous and how helpful this presentation was. So I'm happy all of you joined today. And like Dr. Sidore said, this is something that professionals, specifically we're working with this population or are responsible for education in this realm, this could be a very helpful presentation. And for all the direct care partners, this is also helpful. So I'm really happy all of you joined today, this lovely Thursday afternoon. But again, we do have time for maybe one or two more questions. One of the questions that we just received actually is, a lot of individuals talk about for the older person signing advance directives, but shouldn't we be starting this conversation when people are in their early 20s and really make it digestible starting from an earlier age?
Yes, that person is singing my song. As I sort of said, I think in the beginning that we're really trying to move this upstream. When you think about people who go off to college, you have to write down an emergency contact. I mean, that's a surrogate decision maker. So I think we can start thinking about this much earlier for sure. And that we're definitely trying to do that. So I wholeheartedly agree.
Thank you. And one more, someone just wrote that when they educate their clients, they really change the conversation, not from just preparing or filling out paperwork, but truly what it means to be like living well, their idea on pain. What are your thoughts on that?
Yeah, I think that's wonderful. Again, whatever we can do to sort of know what is important to that person. And like I said, getting that person's story and understanding them as a person, like that's really where it's all at. So I think that's great.
Well, I think you answered a lot of the questions. Again, I can't thank you enough for volunteering your time and expertise. And again, I thank everyone for joining us today. We will be having our next Care Connection webinar in July, and I hope all of you can join once again. And I hope everyone has a wonderful rest of the day. Thank you, everyone, for joining, and hope to have you all back on again next month. Have a good day, everyone.
Thank you. Thank you so much.
Thank you.
Bye.
Thank you. Bye-bye.